contracting is, what does the contract mean to you in terms of revenue and expenses? So, you know, we always think if I contract, it's all revenue, but it's not. If you can't operationalize a contract, or if it costs you so much to operationalize a contract in your office, and you're not making money, then why would you want to go into that contract? So you really got to, you know, analyze it. And then you have to think about when you're looking at your contracts every year, how would you replace any patients or the revenue you might be losing if you decide not to sign? Because let's face it, if you're new in practice, you want patients and you want to get paid. Not everybody goes into practice and says, I'm going to be a cash basis practice. They're relying on insurance plans. And then you have to look at, in the market, what are your alternatives? Because maybe you decide you don't want to contract with group health because you feel like that with the panel of patients you get from Premier and Regions, which are better contracts, easier to operationalize, that you'll be able to handle it with that. So you really have to think about that. Because I think that when people, especially they're brand new, is they're going to contract with, I contract with everyone. I've talked to some new providers. Oh, Janine, I contracted with everyone. And I thought, oh, that's a mistake. There's some plans you may not want to contract with. So, and then I also think number two, how does the contract define medically necessary care? You know, you want to make sure that in the contract language, they don't get to decide what's medically necessary for the patients. Sometimes we don't have total control of that, but there are some really poor contracts out there where they use this denied as medically unnecessary provider write-off when they're not applying a standard such as prudent physician in the managed care organization, nor do they offer any way to appeal it or make an appeal. So you don't want to give you don't want the insurance plan having all that control to make decision. You want to be able to look at, and most plans have gone to this now, at least larger plans, where they publish their criteria, and it's based on you know, research, what drug is you know, considered experimental, etc. So the other thing that I talked about is operationalizing it, and that is, how does the managed care organization verify that a patient is enrolled in the plan? So are they going to offer you something, a quick way to know that this patient is yours? You can verify the eligibility, because you really want to, you don't want to treat them. If they are assigned to you and it's a closed door HMO or a closed door managed care plan, you're going to see them and then you're going to get a denial that says, well, you may have thought they're yours, but they're not, and you didn't have a referral to see them, so we're not going to pay you at all. So you have to really be able to have an easy way. So there's a lot of different ways to do that. Any of you use One Health Port or something called real-time eligibility? A lot of you have it. It's part of your systems. Or you'll go right out to the health plan and you'll be able to look it up, or they might send you your eligibility list monthly. So you want to make sure the patient belongs to you. And you don't want it to be a phone call, a 15-minute time on wait every time your folks in the front schedule them. And then, does the plan stand by this information, or does it reserve the right to reverse itself, or what we call retro-eligibility? You know, you've treated somebody for 3 months, and then they say, oh no, they didn't have that coverage. So they take back all their money, even after they paid. Or anything that's not paid, they deny it as not eligible because their eligibility is not up to date. And so then you're left thinking, okay, now I got to contact the patient, got to figure out what coverage they had. Oh, and by the way, they didn't have any coverage for 3 months when you provide all those services, so now they're a private pay patient. You haven't made any arrangements for the private pay patient. You may have a policy that says people who don't have insurance need to pay a percentage of each visit. But now what you've got on your books is debt that you've got to collect after the fact. So something you weren't counting on when you're kind of doing your monthly predictions of the money coming in. And then also, this goes back to you in behavioral health, and I know because I have a lot of behavioral health providers, behavioral health benefits are really changing. So how do you figure out before you provide something to a patient, because they look to you, whether the patient has that as a covered benefit, or how do they determine that your 10 visits are medically necessary versus they say there's a 5 limit cap on it, something like that. So it goes right back to that. How you do that is, when you're contracting, you ask for that information. Does the contract have an administrative manual? Any of you contract with L&I?
Yeah,
You seen their new administrative manual?
not lately.
It's a ream of paper. It's this big. It's huge. But it's good. It's updated July 1. It has an answer for everything in it. You can bring it in on PDF. The neat thing about it is you can search by words, and they've really done some things to make it better. But if you contract with someone and they don't have such a manual, then you don't know if they have special billing rules. You don't know, what you need to prior off. Did I need to get a pre-auth before I provided that service? Well, geez, I didn't know, because my health plan didn't do that. So what you wanna do is, when you're contracting, you wanna bring that health plan in, and you wanna sit down with them, and you wanna say, show me the tools you have. How do I know that, what services and procedures are subject to prior authorization? Do you have a list? And if it exists in writing, can I get a copy? And does the plan provide an efficient, reliable mechanism to obtain prior authorization, which is available 24/7? Does the plan provide in writing the process to obtain prior authorization? So remember, with number 1, I said to you, when you look at a contract, you have to figure out what's the expenses of contracting with them. I mean, if it is overburdensome with prior authorization requirements, it's gonna cost you more to provide the service than you're actually gonna get back. And you have to make those determinations. You ever had your staff on the phone for 45 minutes?
Oh, yeah.
That's 45 minutes. You gotta put that in the equation. So then, number 6 is, what is your reimbursement by CPT codes or claims payment, right? Because I think what we all kind of look at is, we look at still that E&M code, that OMT code, that behavioral health counseling session time code, to the fee-for-service amount that you're gonna get paid for it. So you need to have a comprehensive fee schedule, don't you? Because one of the things you don't wanna find out is, you don't wanna find out that, for this level of physician, say a DO gets paid this much, but say you have a PA or an ARNP that's working in your office. So you're gonna take, my docs like to say this, a haircut, a 15% decrease every time they see someone. You need to know that. If you're in behavioral health, is there a different payment level depending on the type of provider that's seeing them? That's in your contracts all over the place. CSW, MHW, just depends. And does the contract compensate you beyond your practice expense? There is a practice expense that we all incur when we're delivering a service. So you may choose not to stock certain kind of drugs or supplies because the reimbursement or provide a service, because the reimbursement for it doesn't cover your malpractice to do it, doesn't even cover the time to provide the service, so you may choose to not provide it. But you need to know that, because there might be a lot of things about the contract that you'd want to provide, but it might help you in your decision to say, we're not gonna provide that service anymore. We're not gonna provide radiology services or whatever it might be. And then, what are your rights to appeal claims payment? So you get a denied claim. So what are your rights? How do you appeal it? Because you really need to know that. If you have no rights, it means they can deny anything. You have no right to appeal. And also, when you go to appeal, you want to educate your staff that's doing the billing for you, or your billing company. I need you to appeal these claims because I disagree. And is the appeals process fair? So you need a description of what that appeals process is. The other thing that we think about with appeals is, right now, L&I is doing audits. So they're auditing from 2009 to 2011. I just completed 3 of them. It was the most wonderful letter I've ever sent to the department. Our attorney, he was not in, I didn't have him proof the letter, and he said, I wouldn't want to get that 9-page letter from you. But really, what we got was, we got a letter in the mail, and it said, we've reviewed your claims from 2009 to 2011, and we want this much money back, and here are our findings. You have 20 days to appeal it, unless you ask for an extension. So I went first to the manual, certainly, that's what we signed with L&I. I did get an extension because it sat on the doc's desk for 2 weeks, so by the time we got it, we only had 6 days and it was a lot of line items. But in the end, I'm not paying them what they want back, and there's an appeals process, and it worked wonderfully. But if there is